We've still got people joining, but I think we'll get going because we've got a pretty action-packed agenda. I'm Hazel Cheeseman. I am the Chief Exec at Action on Smoking and Health, and welcome to this update on vaping in pregnancy that we're having today. We've got a lot of people registered, should have around 400 people registered. So hopefully lots of interesting conversation that can be had in the chat as we hear the information from today. Do you want to go to the next slide, Noah? Just in case you don't know who we are, ASH is an independent public health charity, and we are working to end the harms from smoking. And we coordinate the Smoking and Pregnancy Challenge Group, and this has been a group running for over 10 years now. And we are a coalition of charities in the public health sector, in the maternity sector, representing kind of baby charities, a whole big range of organisations, and we've been working really hard over the last decade on what's needed to reduce rates of smoking in pregnancy, and that's been a combination of both national advocacy and campaigning, where many of the recommendations that the challenge group has made over the years we have seen implemented, but also practical support and guidance for health professionals, and I think that's really the focus of today's activity. And just to be clear that we don't have any commercial conflicts of interest with e-cigarette companies, tobacco manufacturers, or indeed pharmaceutical companies. So we just move to the next slide. Bit of housekeeping. So everyone should keep themselves muted, keep your videos off unless you're presenting. ASH staff will otherwise mute you. Keep the questions coming, and we'll try to get to as many as we can when we get to the Q&A section. Really, and other reflections as well. These events are often very helpful, and just in the chat where people share information and with each other, which I think is very useful. It is being recorded, and the recording and the slides will be shared online. And if you have any other issues, then drop a line to that admin at Smokefree Action email address, and we will try to fix them. Next slide. Thanks, Noah. Okay, my remarks briefly, and then we will move to hear from Professor Peter Hajek, who's going to give us an update on the evidence around vaping in pregnancy. Then we'll hear from John in our team at ASH around the new guidance from the Smoke-Free Action Coalition, the Smoking and Pregnancy Challenge Group on vaping during pregnancy. And then we will look at a particular example in Greater Manchester of how vapes are being used as part of their approach to smoke-free pregnancies. And then hopefully we will have left time for a Q&A, but given I'm already running a little late, let's move on to the next slide. So just to be clear about why we're talking about vapes today, I mean, all of you will know that these have become a very popular aid to quitting smoking in Great Britain, and they're very widely used now. Over half of the people that have stopped smoking in the last 5 years, according to our data, have done so using a vape. So these are just a very commonly used device. Obviously, they're increasingly also being used by stop smoking services, particularly as part of the Swap to Stop scheme. And different local authorities and NHS organisations have taken different approaches to kind of integrating them into their support around pregnancy. So it's really important that health professionals understand what the latest evidence is around vaping and the kind of practical ways that we can use them in our services, and that's what we'll get to today. And I think it's important as well to come back to the position of government nationally, and as Professor Sir Chris Whitty says, that if you smoke, vaping is much safer, and if you don't smoke, don't vape. Marketing vapes to children is utterly unacceptable. And we're not going to talk a lot about the marketing to children, the use among children today, but people may have seen that the government have published a call for evidence today relating to the Tobacco and Vapes Bill, which is before Parliament. And there are other areas of policy which are progressing, which will help to address the appeal of products to teenagers, but it's not going to be the focus of the conversation today. Next slide. And of course, if any of you really need reminding why it is that it's so important that we reduce smoking in pregnancy, and why it is that we're looking at vapes as an aid to that, the very many poor outcomes that people can have as a result of smoking in pregnancy, and as a result of being exposed to secondhand smoke, and that can't be reiterated enough. Okay, well, I think you've probably heard enough from me, so I think it's time to move to the experts. So without any further ado, I will introduce Professor Hajek. So Peter is going to speak, as I say, to the evidence on the latest evidence around e-cigarettes and pregnancy. And over to you, Peter.
Thank you, Hazel. So I was asked to do an update on safety and efficacy of e-cigarettes in helping pregnant smokers quit. Next slide, please. Like all other smokers, pregnant smokers sometimes try to limit the risks of smoking by switching to vaping, and that's actually pretty much more common than pregnant smokers trying NRT. Now, it's quite important to realize that both of these products are NRT and e-cigarettes are very similar. E-cigarettes are basically a form of nicotine replacement treatment. They are much closer in safety to NRT products than to actual cigarettes. They just contain nicotine, propylene glycol, and vegetable glycerol, which are considered safe, and there is some potential risk from the flavorants which people are inhaling. But in terms of risks, this is all, very close to NRT and very far from smoking. Now, that, of course, leads to an obvious logical conclusion that for pregnant smokers who can't quit otherwise, it would be a good idea to use e-cigarettes, which is the attitude here in the UK, where pregnant smokers are allowed or even encouraged to use vapes, but not in America, where pregnant smokers are advised not to use e-cigarettes. Actually, in America, general smokers are not advised to use e-cigarettes, but that will be for another discussion. Next slide, please. This is just an example of the UK approach to this, a very useful leaflet, just the second part of the leaflet produced by Ash with collaboration with Tommy's and others, emphasizing that vapes are significantly less harmful than tobacco cigarettes. Next slide. Now, the very important question for us when we are recommending nicotine replacement treatment or e-cigarettes to pregnant smokers is whether there are any risks of nicotine for pregnancy. If there are, it would still be a good idea to switch to nicotine only from all the other stuff, carbon monoxide and heavy metals and so on, which are in cigarettes. But it's quite good to consider what nicotine does to pregnancy. Now, smoking generally, nicotine plus the other products or just the other products, is certainly causally associated with restricted prenatal growth, and that's the main effect of smoking. So smokers have higher incidence of low or premature birth weight. Low birth weight is defined as babies weighing less than 2.5 kilos, lower average birth weight, and small for gestational age babies. And we know that this is causal. That's not because of some other characteristics of pregnant women, because of this beautiful study looking at assisted reproductive technology children. So these are surrogate mothers, and they may be carrying their own embryo or embryo of somebody else. And if the mother smokes during pregnancy, whether she's genetically related to the baby or not, the baby will have lower birth weight. And that shows beyond any doubt that smoking causes this. But looking, for instance, at attention deficit hyperactive disorder, which is also associated with smoking, this is not caused by smoking. It only, there is a relationship only in genetically related mothers. Next slide, please. There's also lots of other negative pregnancy outcomes which are associated with smoking, and where smoking is considered to be an important causal factor, but which may be influenced by some other factors. So women who smoke are more likely to have higher levels of stress, to use other drugs, to have psychiatric illness, to use medications, to live in poverty. And all these factors are also associated with these other outcomes. Now, there's also associations of smoking pregnancy with behavior and cognitive outcomes, but these are now quite clearly the result of genes rather than the result of smoking. So the association is sort of coincidental. Next, please. So Does nicotine contribute to these effects, particularly on prenatal growth? We can look at these three different venues of examining the issue. Next slide, please. We can look at NRT versus placebo. And in these studies, people using NRT versus placebo didn't have an increased risk on anything. And in the largest study, nicotine arm actually had better birth and infant outcomes for 2 years postpartum than those on placebo. Now, all these women smoked at least for the first 3 months of pregnancy, many of them longer. And so this only applies to nicotine use in late pregnancy, but nicotine use in late pregnancy does not seem to have adverse effects from this. Next slide, please. This would require some time, and I was only given 15 minutes, so I won't go in details, but the snus use data are important here because snus, of course, contain other tobacco chemicals than nicotine, and so if it was shown detrimental, it could still be the other chemicals. But if snus is shown not detrimental to pregnancy, that would exonerate nicotine because snus delivers actually more nicotine than smoking. And the data are mixed. The important study looking at siblings where one used snus and the others didn't show any effect of snus use. The newer samples also don't show effects of snus use. The older samples do, much less so than smoking. You can see in the second line that birth weight in smokers, 190 grams, lighter babies than non-smokers, snus use is only 39. But these were mostly from the time period when a lot of these snus users were smokers. It was 30 years ago when, like nowadays with vaping, smokers are trying to limit risks by switching to an alternative, and that was happening in Sweden at the time. Newer data don't really show it, but a review which puts all the new data in, somewhat selective data use, shows a small effect. So on the basis of this, I can't rule out an effect of nicotine. I don't think there is one from this, but I can't rule it out. Next one, please. And regarding e-cigarette use, this is the largest study of this, looking at low gestational weight gain, that's mothers during pregnancy. And this was more common in smokers and dual users, and vapers and non-nicotine users have the same. So again, doesn't suggest a major impact of nicotine use on intrauterine growth. Next, please. And now the update, there's a new meta-analysis just published, which actually claims that it shows that vaping is risky in pregnancy. And the data actually don't do that. There's a bit of a swindle going on. We see that often when the authors have an agenda and want to show that vaping is dangerous, you often get headlines which do not fully correspond with what the study actually found. So the headline here that vaping is risky for pregnancy does not really correspond to this finding. This is because the headline is based on a comparison with vapers with never smokers. And these women were all smokers. They smoked early in pregnancy, some of them until late pregnancy. And so the comparator group really needs to be smokers, not people who never use nicotine. And there the results actually suggest a benefit rather than a risk of vaping. I'll show you the actual findings. Next slide, please. So this is looking at low birth weight, and the incidence of this was higher. The first line shows that it compares never users of nicotine with vapers, and indeed vapers had more low birth weight than never smokers. But the relevant comparison with smokers and dual users, which are the lines underneath, and there it goes in the right direction. So these vapers, who switched from smoking to vaping, 25% lower risk in one and 47 or 43% in the other. It didn't quite reach significant, but if you look at the next slide, where this is small for gestational age babies, another measure of prenatal growth. You can see again that vapers did worse than never smokers, but they did significantly better, actually halving the risk of this compared to people who continue to smoke, and the same for people who became dual users. Next slide, please. Now, coming to our own studies of this, we did a randomized controlled trial comparing e-cigarettes and NRT in pregnancy. That's a few years back, published in 2022. Next slide. And it showed that vaping helps with quitting smoking, and also help in those who don't quit smoking, they at least reduce their cigarette consumption. Next slide, please. And regarding safety, vapers had no more adverse effects or serious adverse effects or adverse pregnancy outcomes than people randomized to e-cigarettes than those randomized to nicotine replacement treatment. But the low birth weight was significantly less in e-cigarette users. That wouldn't be because e-cigarettes somehow protect you, it was simply that they smoked less, and so there was a benefit to pregnancy outcomes. Next slide, please. Now, we did a secondary analysis of the trial, which was published last year, where we looked at not just people randomized to one or the other, but for people who actually regularly used nicotine during pregnancy. And this was to see what effects nicotine use have on pregnancy outcomes, whether it's from NRT or from e-cigarettes. More people used vapes throughout pregnancy, almost half, but there was a good chunk, almost a quarter of people who used NRT regularly during pregnancy. Now, we looked separately at people who were abstinent and those who continued to smoke, and nicotine users didn't differ from non-nicotine users in either of these groups. So this shows that the extra nicotine did not do any damage to their pregnancy outcomes. Importantly, next slide, please. The birth weight was better in people who used nicotine regularly than in those who didn't, among people who stopped smoking. So infants of women who stopped smoking but used nicotine regularly weighted 3.3 kilograms, and smokers 3.1 kilograms, sorry, compared to smokers. Now, we only had a small sample of women who stopped smoking and did not use nicotine regularly. Remember, this was over 1,100 people. Only 18 quit smoking without any nicotine, which shows you actually how difficult it is to stop smoking in pregnancy. And so this wasn't significantly different from either of these two groups. Remarkably, as in our other studies, e-cigarette users had significantly more improvements in cough and phlegm. That could be because propylene glycol kills bacteria and viruses and may actually protect vapors from airborne infection. Okay, last slide. I see Hazel there hovering. We have, if you are advising pregnant smokers who are trying to quit and find it difficult, you can tell them that there's a large trial showing that quitting with e-cigarettes leads to better quit rates than quitting with NRT, has the same safety profile as NRT, but mothers who were given e-cigarettes had a reduced risk of having a low birth weight baby. Now, I wanted to add something else at the end of this talk, which I clarified with Hazel before. You may know that once a year we do an update for Stop Smoking advisors on new developments, and there's a bit of supervision and troubleshooting, and it's a one-day event. And just in case you're interested in that, I'll put the email where you can get more information about it in the chat. And I stop there, and I don't know if there's any time for discussion or not, but pass you over to Hazel.
Thanks, Peter. Pretty much bang on time there. Well done. I will move us on quickly, and thank you for those of you who are posting kind of comments and questions in the chat. There's some good ones there for us to come back to in the Q&A session. Lots and lots of rounds of applause coming, virtual rounds of applause coming your way, Peter. So handing over now to John from the ASH team, who's going to go through the updated guidance from the challenge group around vaping. Over to you, John.
Thanks, Hazel. Hi everyone. So I'm John. I'm Policy and Public Affairs Manager with Ash, and yeah, I'm going to give you a quick run through our latest guidance on vaping and pregnancy. Next slide, please. So the Smoking in Pregnancy Challenge Group first produced guidance on vaping during pregnancy, I think back in probably 2017, 2018, and this was in response to the fact that lots of women were coming into pregnancy, either as vapers or they were asking or interested in using vaping to quit smoking during pregnancy. And service users had lots of, professionals, and so we've done our best to try and service professionals had lots of questions. Sorry, and we've done our best to try and answer those questions in this guidance, which has been updated a couple of times over the years, including at the start of this year. And you can see on the right the organisations that have endorsed that guidance. So kind of maternity, baby charities, Royal Colleges, a whole range of kind of health organisations. And this guidance is designed to support professionals to have those evidence-based conversations, respond to concerns and questions from service users. And the guidance consists of a detailed FAQ-style briefing for professionals, kind of key messages, at a glance version of that briefing, and then an infographic for patients, and they're available online there. And I also put the link in the chat earlier. So next slide, please. So this just is a screenshot of the kind of detailed guidance, and yeah, you can just see it there. So FAQ style, suggested responses, detailed kind of summaries of the supporting evidence. And as I said, there's a shorter key messages at a glance version of this document as well. And then next slide. You can see there, that's just the infographic for patients, and again contains most of the same information in the detailed briefing, but much more condensed and kind of service user friendly. And this is designed so that you can kind of give it to service users, you can talk it through with them, but then they can also take it home and it can be something that they use themselves as well. So next slide, please. So what are the key messages in the guidance? And a lot of this will reiterate things that Peter highlighted in his evidence update. So in the short and medium term, vaping poses a small fraction of the risks of smoking. However, it's unlikely to be risk-free, particularly for people who've never smoked. We don't have the data on the long-term health impacts, so kind of 10, 15, 20 years, although evidence indicates it's likely to be much less than for smoking, but again, not zero. So while licensed nicotine replacement therapy products such as patches, gum, and inhalers are the recommended option by NICE, vapes appear to be, as Peter highlighted, more effective for smoking cessation during pregnancy than NRT. Certainly, the evidence shows that vapes are more effective for smoking cessation in the general population than NRT as well, so it makes sense that they would also be more effective during pregnancy, and that regular use of vapes or NRT, so both nicotine-containing products, during pregnancy does not appear to be associated with any adverse effects in mothers or their babies. So if a pregnant woman chooses to vape, and if that's helping her quit smoking and stay smoke-free, then she should absolutely be supported to do so and shouldn't be discouraged from doing so if the alternative is smoking. Unlike cigarettes, vapes don't contain or burn tobacco and don't produce tar and carbon monoxide, which we know are the two of the particular substances which are really harmful to developing babies. And as I'm sure many people on this call will know, many services have integrated vaping into their stop smoking offer for pregnant women, and this should not be discouraged if it's helping women to quit and stay smoke free, which needs to be our number one priority. Next slide, please. So just touching on a few other issues. So obviously youth vaping is something that is a lot of concern about. It comes up in the media a lot, quite understandably. And so our line on this is vaping is an effective quitting aid for adult smokers, but it should not be used by under 18s. So anyone under 18 who is either vaping or smoking should be strongly discouraged from doing so, and it's illegal to sell or provide vapes to someone aged under 18 as well. Peter's already gone through nicotine, so I don't need to go into detail on that, but just to reiterate, while nicotine can be addictive, it's not associated with the vast majority of the harms from smoking. Nicotine in the form of NRT is widely prescribed for smoking cessation to adults, pregnant women, and children aged 12 plus, and it's recommended by NICE as well. So thinking about non-smokers and vaping, so someone who vapes and has never smoked should consider quitting vaping, as it's not risk-free, it's addictive, and it's not going to offer you any benefits if you're not trying to maintain a quit attempt. In terms of vaping cessation, people who have quit smoking through vaping should be supported to keep vaping as long as necessary to stay smoke-free. The key priority is that people are not kind of pressured to quit too soon, because that might increase the risk that they relapse to smoking. We know that rates of relapse during pregnancy and postnatally are really high, and so our priority needs to be giving women whatever support they need to maintain that quit attempt. And if that's through vaping, that's through vaping. If that's through NRT, that's through NRT, whatever it is. And then in terms of secondhand vapor, so currently there's no evidence of harm to others from secondhand e-cigarette vapor, although the evidence is very limited and still emerging, and it's possible that longer term exposure in an enclosed space may carry some low level risk. And so pregnant women and parents could consider not allowing vaping indoors or around children, or newborn or young children, just as a precaution. You know, in an ideal world, the only thing we want children and babies to be breathing in is clean air. But the key thing again is that pregnant women and babies are not exposed to secondhand tobacco smoke, which we know is extremely harmful, and we need to avoid at all costs. So next slide, please. So I've just included this slide to help give a bit of context around public kind of perceptions of the risks of vaping compared to smoking, and to kind of highlight why it's so important that professionals are able to have these evidence-based conversations about the kind of risks of vaping compared to smoking. So as you can see there, and this is taken from our annual survey of kind of adult vaping behavior and perceptions, you can see there that the vast majority of adults, and this includes the majority of smokers as well, think that vaping is at least as harmful, at least or more harmful than smoking. And so that's the dark grey line that kind of sharply increases from 2022 onwards. And this has really been driven by a kind of increasingly sensationalist media reporting on vaping, which effectively, you know, only really tells one part of the story. So the kind of scary potential risks part of the story, and not the effective for helping loads of people quit smoking without any serious adverse impact part of the story. And so that's really kind of warped public perceptions and professional perceptions as well. And the kind of real world consequence of this, and why this is concerning, and why resources like our briefings are trying to help address this, is that this leads to fewer people quitting smoking because they're worried about the kind of the harms of vaping, more people dual using, so both smoking and vaping concurrently without fully switching to vaping because they're worried about the risks, even though they're already smoking, which is much more harmful, and people who have managed to quit smoking through vaping relapsing to smoking because they think, well, better the devil you know. These are all outcomes we really want to avoid, obviously. So next slide, please. And so where can you go for reliable information? Obviously, I'm sure as many of you have found, if you've Googled this, it's a complete minefield out there. And so I've tried to just pull together some of the kind of reputable evidence-based sources. So of course, I would say that ASH Challenge Group Guidance is probably the most comprehensive summary of the kind of evidence and recommendations around vaping during pregnancy to date. And, you know, we review this annually. If the evidence changes, our guidance will change. NICE guidance, the NCSCT, National Centre for Smoking Cessation and Training, have really helpful guidance on vaping for health professionals. I can see you've popped up, Hazel, so I'll speed through. The NHS website actually has really good guidance on quitting smoking during pregnancy, which addresses e-cigarettes as well. The Royal College of Physicians last year conducted a really thorough and quite technical evidence review for those of you who want some bedtime reading, which goes through all the kind of the risks and evidence around vaping, including during pregnancy. And then there's also the 2022 OHID, Office for Health Improvement in Disparities, government review as well. And so just to conclude, health practitioners should base their advice on good quality evidence, such as systematic reviews, not from media headlines. I think there's one slide, but I can probably just skip past it. So this just gives you an overview of incoming vaping regulations. So tobacco and vapes bill will ban advertising and introduce real restrictions on vape marketing and packaging to prevent them being marketed to children. And a couple of other things as well. And collectively, these will play an important role in reducing youth vaping and kind of illicit underage sales, whilst making sure these products continue to be available to help adult smokers quit. And I think that's it from me. Thank you very much.
Thanks, John. Tour de force. We'll move on to hear from Jane Coyne from Greater Manchester. Thanks for all the commentary in the chat as well, and we'll get to those questions. A few questions from Kenneth. Unfortunately, he has to leave, but you can listen to the recording, Kenneth, and we will pick up on the points and the questions that you make. Jane, over to you, and with the experience in Greater Manchester of the role of vaping in supporting women who smoke to quit. Thanks.
Oh, lovely. Thanks, Hazel. Hi, everybody. Lovely to see you today. You can move slides on. Thanks to me, Noah, if that's okay. So obviously, you know, I know many of you know about Greater Manchester, but it's obviously just a reminder that we wanted Greater Manchester to be that place where everyone can live a good life, grow up, get on and grow old, and really have that wider making smoking history strategy. Often sat behind that with the WHO framework, but we've taken a whole system-wide approach to this, with our pregnancy programme being that kind of one of the pieces of our jigsaw that will help us achieve the long-term plan and overall reduce our prevalence of smoking across our city region. Thanks, Noah. And obviously, why did we do this? So the programme's ambition was obviously to make smoking history and reduce the number of women smoking during pregnancy and obviously at the time of birth. We have about 36,000 births annually across Greater Manchester, and when we started, our smoking at time delivery rates were just under 13%. That covers 10 localities with 6 maternity providers across the city region, one being one of the largest tertiary centres in the unit. So often we see lots of people from around the UK as well. And I think just a reminder is that we use our incentives as well as NRT to really improve those outcomes for women. I'd be remiss of me if I didn't mention that. Thank you. Next slide. And as we've already mentioned, you know, there are so many key factors around smoking in pregnancy, but it still remains the single most modifiable risk factor for adverse outcomes in pregnancy and also in our wider population. But the death of a baby has significant psychological, social and economic consequences for parents and their families, which will ripple for years. So it's trying to hold that in our hearts when we're doing some of this, obviously understanding the risk of preterm birth and obviously all the other factors we've talked about earlier today. Thanks, Noah. Next slide. So what did we do? Obviously, we implemented our system-wide programme in March 2018, aiming to tackle health inequalities, improve health and wellbeing, and obviously our ultimate aim to save babies' lives. And we took a whole systematised approach with that, offering training around carbon monoxide testing, very brief advice, and obviously the implementation of bespoke maternity stop smoking teams who would kind of offer that free stop smoking support and medication. And obviously that was NRT, and obviously later on, I think it was about 2020, we began to offer a vape and liquids up to 3 months postpartum alongside our regular carbon monoxide testing incentive scheme. And we've used our data in that, so we can do real-time data updates and see kind of where we're at the touch of a button. And this has been a whole system collaboration, so that no matter where you were, we didn't have a postcode lottery across Greater Manchester. Our response and our effort would be the same. Thanks. Why did we include vaping? Well, we took the evidence, you know, from NICE and from other areas that vaping was significantly less harmful than smoking. And obviously we knew that the prevalence of vaping was rising. So lots of women were coming to our services asking for vapes, telling us they were vaping, often buying or making their own liquids, buying or using other people's devices. You know, so we wanted to make sure, especially that we were being safe in our offer, that we knew where they were coming from. Obviously, we use Article 5.3 in Greater Manchester to try and safeguard ourselves and obviously not engage with the tobacco industry. So we wanted to make sure the products that people were using were actually safe and obviously, you know, not being targeted by big tobacco. And we knew it was a harm reduction tool for those who were struggling to quit. And often we saw from our data that most women only used NRT for 4 to 6 weeks. They didn't like it, they didn't want to be in it, and they found that quite restrictive. So we found that women were sometimes relapsing further down the line, and they were coming saying to us that vaping was helping them to prevent that. And obviously we knew that vaping would be that bridge to quitting by a less harmful mean. Thank you. So what did we provide? So we worked with Totally Wicked as our first provider when we started the scheme. And obviously through the national scheme now with Swap to Stop, we're working with different providers. I think we've got Dinner Lady in there as well, obviously vetted to make sure that nobody's working with big tobacco. But we make sure everybody's provided with a really nice bundle so they get the device of their choice. And we have a choice of devices so that women can choose one that suits them. And obviously up to 12 weeks supply of liquid. Choice of flavours, and I think we've got a little bit at the minute where they're wanting smoother ones as they're finding they're a little bit easier on the palate, and obviously a nicotine salt variant, like I said, gives that smoother taste as well. Approximately at the minute, we're giving about 400, we've issued about 400 devices about every 3 months. So these seem to be going flying off our shelves, and we're really finding that women are quitting from them and remaining quit through our programme. Thanks, Noah. Obviously some highlights. I think a lot of people have said, from one of our directors of midwifery, this has been a huge success. We've seen more and more women quitting smoking. I think our smoking at time of delivery rate is now 4.7 according to MSDS in Q1, which is phenomenal. But the staff have really enjoyed being able to give something. If anything, I hear from staff all the time is that they struggle with NRT and the point of care and issues with posting and how that's delivered because they're not registered staff. Whereas actually we can provide vapes at point of care. So that could be in a woman's home or at a point of her choosing. So they can actually start that journey while they're looking for the medication. So this vaping is not a barrier to actually women starting on their quit journey. Midwives have been trained, so we give everybody that same consistent advice, so we know everybody's offering the same training, the same information. And we've got a really good peer network. So through our local stop smoking services, our DPHAs, our midwives, we really have that network, and through our alliance where we can share our information and obviously using data to inform where we're going with this as well. Thank you. And just our programme outcomes, like I say, I think this year, at the end of the year for last year's data, we had 7,000 smoke-free babies, which is just phenomenal. And we don't know how many of those babies, as Peter says before, might not have been here already if this programme wasn't in place. Our SATOD, I didn't change the slide from Q1 data, so apologies everybody, but our SATOD was actually 4.7 from 12.6. The teams in Greater Manchester are phenomenal. The midwives and their TDAs are just doing this day in, day out. And I think what was really important for me when I looked at some data last week is that our babies and those who've quit are now about 360 grams heavier than those who quit. And I think some older information studies was about 200, 220. So we're really seeing a bit of a difference there in what we're doing. And thank you, Hazel. Sorry, I've got the chat open. It's sometimes a bit distracting when you see that coming up, isn't it? But obviously we're seeing numbers engage, and this has just been a phenomenal piece of work for me as a midwife in saving babies' lives. Thank you. So I've just give you a little bit of that, and obviously, like you said, we've helped over 10,000 women throughout this process, and I think vaping has been key to that. And I'm sure my advisors would talk to how important it is that the action of this and being able to do something when they're in that kind of changeable moment and it's teachable and we want to give something, vaping has really helped that. And also they can be given by, physically, or obviously we use vouchers for some women as well, as they want more liquids so that they're more accessible to different shops. And I think what's been really good for us as well is that engagement with our vape shops across our city region. They wanted to understand training and be talking about vapes in the right way to our pregnant service users as well, which is fantastic. Next slide, please. Like I say, SATOD is significantly declined. I think we're over 50, well over 50% now since we started this programme, and our trajectory was 4% by 2028. And I think the work that our teams are doing is they will be surprised if we don't see that, drop even sooner. I think we've seen the greatest improvements in our most deprived boroughs, and obviously when this programme is to aim up level those health inequalities, that's absolutely key. It's showing those positive trends for smoke-free babies, and we are obviously working with Manchester Foundation Trust and Stirling University, my Professor Michael Usher, in looking at, I think somebody's comment was in the chat, how we begin to look at vapers versus non-smokers and things like that. So we've got research ongoing, and obviously looking at our research as always against smoking, because this is the aim of what our use of vapes in our programme is aiming to do. Thank you. So I think what we learned through doing this, that consistent messaging is critical. I think when you've got those mixed signals about safety of vaping, or professionals don't understand that, then obviously then they're not able to have those good conversations with women and to give that kind of unbiased view about vaping. Clear clinical governance is absolutely key, and like robust supplier checks. So, we work towards Article 5.3. We do not work with any agency who would be seen to be working with tobacco companies. And I think it's really important that we integrate them into our wider support system, and it's not a standalone fix. This has to work alongside that relationship with the treating tobacco dependency advisor, that bespoke behaviour change information, and this is treatment that runs alongside that. And I think it'll be important as we move forward and we have our digital system that we can monitor usage and kind of review that over time. And I think, like you say, I think somebody mentioned that in the chat, there is a call for people wanting to stop vaping, and I think there is some work for us to do, and we've talked about that a lot of in our services, so talking to women about reducing the percentage of nicotine in the liquid, you know, moved on to an NRT product if that's something they so wish. So there's lots of ways of looking at that, but I think some national thinking about that would be really useful. But I think for us, we want to continue down the vein that we're going, you know, keep analysing devices, understanding from women what works, because the main thing of this, we want them to remain smoke-free so they do not go back to using tobacco. Obviously maintaining that health of our outcomes for our infants and making sure we can get those long-term quits going for good. Lovely. Thank you. Thank you very much.
Oh, Jane, brilliant. Ahead of time. Well done. I think really important as well to see in what you're sharing there, the way that, you know, what vapes are within the Greater Manchester context is an additional treatment in the context of a high quality, evidence-based, you know, pathway and treatment offer. And you know, it's not like none of these things are silver bullets on their own. You know, it's a tool in the toolbox. Right, Peter, if I can invite you to join us, we've got lots of really interesting questions to get stuck into, and I think particularly want to pick up some of these questions around you know, evidence of harms, and you know, the comparison. Is it valid to look at the comparison only between vaping and smoking? You know, should we also be looking at what the evidence shows us about vaping in pregnancy compared to not doing anything at all? So interested if you could speak to that, and then maybe we'll pick up on some of these other questions around, you know, what the evidence does and doesn't tell us. Peter, I think that question around, you know, plainly we're not recommending that vapes be used in pregnancy if it's not as an alternative to smoking. But I think that question around, well, what do we know about vaping compared to not doing anything at all? And what are the messages that we are giving? Maybe the question around the messages that we're giving to pregnant women would be better for you, Jane, but perhaps you could speak, Peter, to the question about what does the evidence tell us about vaping compared to not vaping or smoking in pregnancy?
We don't really have data on it because up to now, regular vaping among never smokers is very, very rare. I know people are often talking about epidemics of youth vaping and so on, but it is experimentation mostly. It does exist that non-smokers become regular vapers, but it's very rare. There's a recent paper looking at a number of sources in the States where there's a particular concern about youth vaping, and they say that regular young people who use vapes regularly, that's defined as almost every day, from different surveys, ranges between 0.5% and 1.3%. So it's it does exist, but it's very, very low. If you just follow the narrative of the media, you would have thought that half the young people are hooked on nicotine by now, and we're talking about less than 1%. Sorry.
But Peter, assuming that it might be an issue in, you know, I take your point that it is an uncommon phenomenon at the moment to have never smokers who become regular vapers, but where that phenomenon is most likely to be concentrated is in younger groups in the population who are obviously much more likely to become pregnant. So, you know, what are the sorts of, and one of the other questions that we had was, you know, you talked in some detail about nicotine because that's often where some of the concern comes from, but what about some of the other chemicals in vape products? You know, is there anything that you would think, you know, we need to be particularly alert to in relation to the never smokers who are vaping?
Yes. Let me finish that train of thought, which I was very slow to unraveling. So because vaping among never smokers is so rare, we don't really have data comparing never smokers vaping with, you know, never nicotine users. So the answer to that was a long-winded approach to tell you that we don't really know. My expectation, based on the data we have, is that there would be minimal or no effect on pregnancy from vaping alone. But I can't guarantee there could be some marginal effect of nicotine on its own. Now, regarding your other questions about other ingredients in vapes, in the regulated vapes, people often say we don't know what's in them, they're all different. It's not really the case. They all have propylene glycol, vegetable glycerol, and nicotine, and the regulated ones will have flavorants, and they will be food flavor, and some of them have been now removed because of some concerns. So, for instance, there are no vapes now which contain this popcorn lung chemical, although that was a false alarm, but it's just not there now. The danger is if you make vaping illegal, as is, for instance, happened in Singapore in a very drastic way, then people will start to use, homemade stuff or stuff made to make it more addictive. And they have the problem with etomidate, which is sort of dissociative drug. And now a proportion of vapes in Singapore, where of course people are still vaping despite the punishment and so on, and they now suffer some side effects of other chemicals which people smuggle into it. But it doesn't happen where vapes are regulated. So I don't know whether that answers your.
That's very. Thank you, Peter. And John, I'll bring you in a second. So Jane, I mean, obviously from what Peter says, there's things that we don't know about. We have confidence that vaping as an alternative to smoking is reducing harms, and we can see that from the evidence that Peter has presented. But plainly, we don't want people to take the risk if it's not as an alternative to smoking. So how does the service kind of deal with that? How do you take that approach, assuming that you either hypothetically or real world examples?
Sorry, Hazel, rephrase that for me. So you mean for those who are sole vapers compared to
so if you've got a woman coming to the service, she says, I've never smoked, but I'm vaping, what would be the advice? How would that approach be taken?
Absolutely. I mean, obviously, I don't do this frontline, and I'm sure some of my colleagues on the call are probably better placed to answer that than me. I think we would obviously always advocate that vaping should be discontinued if you are not a smoker, because why would you be vaping? That is the guidance from the chief medical officer. I think we would obviously then explore the strengths they're using. Can they reduce their strengths? And then also, could we offer another form of nicotine replacement therapy? So it might be, if it's that hand to mouth thing, could it be an inhalator? Is it something that we can replace that with? So it's understanding, I suppose, why the need for vaping. Is the smoking, and probably there has been past smoking at some point, really getting under the skin of that. And then if they really want to reduce the vaping, then obviously we would look at probably nicotine replacement therapies as an alternative.
And that builds on some of the other questions that people had. And, I think you pointed out as well in your presentation, there are people that want to reduce the amount they vape or stop. And certainly it's something, with NRT, we tend to provide a kind of structured program around the use of NRT. And then, obviously if people want to continue to use NRT, they go and buy their own. What's the approach that you take within the service to that?
So I think that varies as well on the person. So there will be I think we haven't got a standard protocol as such in Greater Manchester. We're working with Matt Everson as our clinical lead to kind of understand that. But we would kind of obviously offer patches, inhalators, whatever kind of NRT we've got on offer to help them reduce that. But for some people, they may just choose to continue vaping.
Thanks, Jane. John, did you want to come in on any of that? Because you had to pop your hand up.
Yeah, I just wanted to come in on the kind of point about the kind of flavors in vapes and the ingredients. So obviously it's really important that people feel are able to have confidence that these products don't contain anything that is potentially harmful, and that we do have a robust kind of monitoring scheme for kind of evaluating the ingredients in vapes and removing anything that's a potential risk. And so that's why, and I put it in the chat earlier, one of the things in the Tobacco and Vapes Bill, which is going through Parliament, is a kind of registration scheme for vapes, which will mean that every product sold in the UK will have to be registered with this scheme, and there'll be kind of regular testing and monitoring of these products and a mechanism to remove any ingredients that are potentially harmful. So that is, I think it's a fair question and a fair concern, and it's something that hopefully will be resolved through legislation quite shortly.
Thanks, John. And there's been a bit of exchanges in the chat. Not everyone might be looking at it around, how to kind of recommend different sorts of products and, you know, which ones you could have more or less confidence in. And I think, you know, to Peter's point, as he was talking about kind of different ingredients, plainly using a product that is legal and registered with the MHRA is crucial. Jane, how did you come to the choice to use the products that you use within the service?
So obviously we did a bit of an options appraisal back in 2018 of all the providers, and obviously looked at those, especially those under Article 5.3, so no connection to tobacco, and obviously did that whole procurement piece. So we got down to Totally Wicked being our preferred provider, obviously taking into account their MHRA sign off with the liquids, etc., and obviously being quite a local company for us, and have expanded that ever so slightly over the last 12 to 18 months, looking at different options and what women are preferring, but really took a bit of an options appraisal approach as to the best provider for us.
Brilliant, thank you, Jane. One of the other questions was around how hard you found it to implement your approach across different trusts, and what helped to bring clinicians and trusts on that journey. So this is somebody who's thinking about taking this approach locally and wants to know how you got it to happen consistently, Jane.
Oh, I think a lot of blood, sweat and tears. No, I'm joking. I think because we have a system, we have a system-wide approach, don't we? I think every trust of ours has a lead specialist midwife for tobacco control, and we sat down as a team, just, you know, definitely wanting vapes, listening to the voice of women. So we kind of looked at procuring that as a system. So obviously we get more economy of scale as well. So as an ICB, we took that role on in providing that to all our providers, engaged through our directors of midwifery and our public health consultants, and Rebecca's on the call today, you know, and really came to a system consensus of something that's what we wanted to offer, and just then built that into our guidance so that became a standard for every person across Greater Manchester within our pregnancy programme who wanted that. What we didn't want to do is one trust offer and one not. We wanted to take that whole system approach in line with everything else we've done. So because of that, I think it was quite easy to bring that in.
Brilliant, thanks, Jane. Peter, if you're still there, we've got a question about nicotine pouches and advice for use in pregnancy. Is there any existing evidence that we can? I know that the evidence around use of nicotine pouches as a quitting aid is still sort of relatively new. Is there any research we can draw on in relation to pregnancy specifically?
Not really. It would be nicotine pouches in the safety terms would be identical to NRT, so there wouldn't be any risks other than nicotine. And as I said, we can't rule out altogether that nicotine may have some adverse effects on pregnancy, although there will be a small fraction of risk of smoking, and there may actually not be any, but there could be some. And pouches provide nicotine efficiently. We just did a lab study on delivery from pouches, and it's pretty impressive and pretty fast. And people may get more nicotine from pouches than they get from smoking. And so probably up to now, I would say e-cigarettes would be a better recommendation than pouches in pregnancy. Whether any studies will be done with pouches in pregnancy, I'm not sure. I'm pretty sure that pouches will be shown to be effective in smoking cessation, but no such proper studies have been done so far.
Yeah, and they were originally developed, I think, as a kind of pharmaceutical tool, and then became a commercial product when that wasn't progressed as a kind of pharmaceutical aid. And you can see they're much more similar to nicotine replacement traditional nicotine replacement therapy products than say a vaping product.
They were initially developed as an RT, and actually it did came to fruition in Canada. Pouches from the original company who started to do this are among the pharmacological treatment for smoking. But these old pouches may not be as efficient in nicotine delivery as the new ones.
Thanks, Peter. And we've got a few questions as well about the impact that you show some really great impacts, Jane. And somebody was asking, have you looked at NICU admissions and whether there's been any impact there? Is that something that you've looked at? Is there any kind of wider evaluation planned that would look at those other outcomes?
Yes, we looked. I suppose we looked a bit that it's probably a while ago, back in 2020, and we saw that we did see a reduction in our neonatal nights because obviously less babies are being born prematurely. We knew we'd spent about £50 million, I think, over about a 2-year period on neonatal bed nights, on babies being admitted early. So I don't think we've repeated that. So, that's something maybe we can pick up in the following year, Hazel. And maybe part of the evaluation Michael is doing with us on our data, we can obviously pick that up now. So we could definitely think about doing that again.
Yeah, and I think that's absolutely, it's so important that we kind of keep gathering the data here. Our understanding of, how to integrate products is evolving. Our understanding of what the impact of different products might be on, is important to keep track of. As Peter was saying, we've got, there may or may not be kind of randomized control trial data on nicotine pouches in the future, but certainly being able to capture use in the population and understand, if people are using them in pregnancy, just gathering those information is so important. I mean, one of the questions that we had earlier in the webinar was about information that is being routinely captured. So somebody, I've forgotten the acronym, I had to be reminded on the maternity services data set. Presumably you and GM are capturing quite a bit of data, but are there things that we should be thinking about nationally capturing as a matter of routine that are not kind of part of the maternity services data set?
I could write you a list, Hazel. I think the challenge is, and if anything, and what my learning is from doing the National Incentive Programme as well, is that I'm sure the providers on the call is we've got such a disparate collection for maternity and stop smoking service data. It would be really good to have that kind of one standard specification that we all submitted data into the same place, and then we can actually compare that data. I know probably a lot of the providers on the call really struggle. It's here, there, and everywhere. We've got bits in maternity records and bits in Excel, and I think there is something about us being able to collect data in the same way, in a kind of standardized and consistent approach, that we can actually compare that data then. But we've got probably getting on for 5+ years now of a full data set of, obviously through our digital platform, from an end-to-end view with some women up to 12 months postpartum as well. So I think there's probably some data mining and things we could actually really look at doing some really good deep dives on, and doing something when I have the time, Hazel.
Always a question of time and resources. I mean, I think if people are, gathering data locally, if you've done your own local evaluations, your own studies, we're always really keen to see them and to share examples of practice, but also those sort of pieces of research which are happening locally, as well as the stuff which is happening nationally. Thank you so much for your time, John, Jane and Peter. I think it's been a really, really interesting session, very lively chat as ever. We'll circulate the slides and the recording, and we've quite a few links to different sorts of information has been added to the chat. The NCSCT guidance on different aspects, including the guidance around supporting people to stop vaping, as all of those things will circulate to people. I will, again, the call for evidence on aspects of the tobacco and vapes bills come out today. You'll expect more from us on that in the next couple of days, or maybe that's a bit too much, maybe next week, on the questions that are being posed in the call for evidence. And there's a great deal happening in this space, both in terms of legislation, but also in terms of policy and research. And it's important that we all try to stay across that. So thank you for your time, everybody, and for the participation today. And look forward to getting together soon to review where we've got to in the future. Many thanks.
Thanks, Hazel.